Okay, so thanks very much to all the organizers for having me here. And yes, we have a problem in patients who are affected by bipolar disorder because they kill themselves, probably because they spend a substantial proportion of their time ill and 3 times more in depression than in mania. And prospective studies suggest that about 30% of their time is going to be spent in a depressive state. So probably as a result of all this, we have that about 30% of patients with bipolar disorder lifetime attempt suicide, and 20% of patients eventually die from suicide, and that are big numbers. And of course, it seems that, and that's the reason of my presentation here, factors affecting sleep could also affect suicide, because systematic review and meta-analysis suggest that sleep disturbances and sleep phase delay are associated with the increased risk of suicidal behaviors, which at the individual level, does it work? Yeah. At the individual level, are shown by phenotypes such as nightmares, insomnia, and whatever, sleep disturbances in general. And of course, we can treat these suicidal intentions by using drugs, because antidepressant intervention prompt remission from depressive episodes, and so can help to reduce the suicide risk associated with acute mood episodes. But you know, there are also concerns. One concern is that there is also this famous black box warning. One concern is that in younger age, antidepressants seems also to increase the suicidal risk when given acutely. But the other problem is that they are slow. They take at least a couple of weeks to show their effect. And of course, sometimes we have not the time of waiting. So there is a deep need for the search of further interventions to treat suicidal patients. And one of these may be wake therapy, which targets the biological clock by modifying the period of the sleep-wake rhythm, and basically consists in keeping a person awake for the whole night, let's say 36 hours, and it has been shown to be effective in the broadly defined depressive syndrome, including endogenous, reactive, unipolar, bipolar, secondary, schizoaffective depression, whatever. Elderly children, pregnancy, all the kind of depressive states have been treated with wake therapy and shown to improve with this treatment. Better effects are obtained, observed along 2 gradients. Endogenous primary depression shows a better response than reactive depression, and patients with bipolar depression show better responses than patients with unipolar depression. So that's the reason why we use this treatment in my hospital as a first choice treatment for the treatment of bipolar depressive states. This is a very old slide of mine, well, not so much very old, let's say 16 years, and we show that these are normalized ratings of perceived mood, and what you expect is that keeping a patient awake, the mood will improve, but then after recovery sleep, there will be a relapse, and then another improvement after sleep deprivation, and then another relapse, and so and so and so, with a typical sawtooth pattern which leads to nothing of importance in a clinical way. But you can sustain this effect and enhance them by combining treatments, which can be, of course, antidepressant drugs, but most important in the case of bipolar patients, lithium, which enhances and sustains the effect of sleep deprivation, and when combined with light therapy in the morning, prompts remission in a substantial amount of patients. So this is currently the treatment protocol that we use in our hospital. So if you come to my hospital and tell to me that you suffer from insomnia during the depressive episode, I will keep you awake, and I will do it 3 times, you see. In a repeated way, along 1 week, we will administer wake 3 times, and of course the night spent awake are interspersed with nights of free recovery sleep, where the patients sleep a lot and have an homeostatic rebound response in their sleep, which also correct the problems in the sleep patterns in the sleep architecture that they have at baseline. And this treatment, this wake therapy, is combined with light therapy in the morning, both given during the wake at night and given in the morning after the recovery sleep. And then there was no space in the slide, but you can imagine that it goes on with the light therapy alone for a couple of weeks to stabilize the effects, combining all those with lithium given at the beginning of treatment. And years ago, we had shown that this prompts remission in a substantial amount of patients. You can see here a study published some 10 years ago, and we show that patients without an history of drug resistance showed a better response rate. This was a study with a 1-year follow-up. And they reached a 70% of acute response, while patients who are resistant to SSRIs are only a 50% response. Patients who are resistant to both SSRI and tricyclic antidepressant treatments, who are the most likely candidate for suicide, you may imagine, because they are desperate, they need ECT or whatever, they respond in 40% of cases. This tells us that factors affecting response to antidepressant treatments also influence response to sleep deprivation. But sleep deprivation adds something to that. And that's important because that tells us that you can use wake therapy and chronotherapeutics, sleep deprivation combined with light, both to treat depression but also to discover new targets. Using it as a kind of a model antidepressant treatment, which in 1 week allows us to have a substantial change in depressive states, and so to investigate the mechanisms which may adding up to the known effects on serotonin, noradrenaline, and whatever. And coming to this last study that I wish to present you, we studied 143 patients affected by bipolar disorder type 1 who were consecutively admitted to our hospital for a major depressive episode in course of bipolar disorder. And we show that these patients, the large majority of them, had some kind of drug resistance. We don't see anymore in the hospital patients who are not drug resistant. Only the 17% of patients was not resistant to drugs, but all the other ones had some kind of resistance, and a proportion of them had also attempted suicide. And the 1 week combination of these lithium and chronotherapeutics was followed by a 70% response rate in the whole group. And considering a 21% relapse rate in the following weeks, this led overall to a success rate of 55.3% of patients who were resistant to drugs and came to be treated with this treatment. So we were very happy. And coming to the pattern of change in syndrome, you can see here the mean Hamilton depressive scores at baseline, and then after the first sleep deprivation night, after the first recovery sleep, and at the end of the week of treatment. And you can see here patients divided according to their final response. These are patients who have a good final response, achieve a remission criteria of having a final Hamilton score lower than 8. And these are patients who do not have this good final response. And they are also divided according to their positive or negative previous history of suicide attempts. You know that positive history of suicide attempts is the major predictor of attempted suicide and successful suicide. And what we observed is that having attempted suicide does not influence response. And also another important thing is that patients who do not respond at the end, they, however, achieve some kind of benefit from the treatment. Some points of Hamilton score go down anyway. And the second point is that when we take into account the patients who have a current suicidal planning or did a serious attempt just before hospitalization, we see that they, however, have a good response. So having suicide in mind does not change response, does not influence response. Of course, these patients have more severe Hamilton scores, but they go down anyway. And coming to the suicidal ideation, here there are the mean Hamilton item scores. Of course, there are patients who have very low scores, but there are also the patients who are a previous, well, that does not function, who have a previous history of suicide attempt, these black points, and they have higher suicide ratings, and they drop to 0 soon after at the first night of treatment. So sleep deprivation targets also these core symptoms and brings them to 0. And this happens also in final non-responders. And there are only the patients who are non-responders and who had a previous history of suicide attempts who retain some kind of suicidal ideation at the end of treatment. But suicide is brought to 0 immediately at the beginning of treatment. And that's interesting. And so the question is, which are the targets that sleep deprivation enables to hit in order to produce these clinical effects? Because we know that it is multi-target in nature, as many also drug treatments are multi-targets. But sleep deprivation and light therapy really targets everything into the brain. They are controlling these basic mechanisms which regulate the homeostasis of the brain, as we will see. And what we know is that sleep deprivation and light enhance the activity of all the known biological targets for antidepressant drugs. Serotonin, dopamine, noradrenaline are increased in their production, in their release of 2 or even in some studies in animal models 3-folds, okay? And this is because there is a dampening in the activity of the circuits during sleep, and of course you keep the patients awake, the circuits continue to work, and you have a net amount of serotonin produced during the day which is doubled or even tripled. And thyroid hormones also is increased, but what I will focus is now with you today is on some mechanisms that we are exploring now and which deals with glutamate. We heard this beautiful presentation before me about glutamatergic models in animals and other things. And glutamate, we know that sleep deprivation alters the circadian cyclicity of glutamatergic neurotransmission and results in major changes in the NMDA function. It modifies the expression of NMDA receptor subunits, and the final effect of this is that it reduces NMDA sensitivity. So Chronotherapeutics is an NMDA antagonist. And this is very interesting because we know that there is one only drug which is able to dampen suicidal ideation in a matter of hours, and it is ketamine, which is an NMDA antagonist. So this is a common mechanism to ketamine and chronotherapeutics. And this suggests that NMDA could be a very good target if we want to immediately treat suicide. But glutamatergic neurotransmission, we know, has an homeostatic circadian cycle. And when we keep animals awake, this is sleep deprivation, you see that glutamate increases to 130% of basal levels, but then in the second part of night awake, it goes down, and after recovery sleep, there is an homeostatic rebound of glutamate, which is reduced. So the whole glutamatergic transmission is enhanced during sleep deprivation and then reduced with this also NMDA antagonism after recovery sleep. And we investigated glutamate into the brain of our patients by means of spectroscopy at 3 Tesla, and you see here the peaks you see here the peaks of glutamate and glutamine, which can be estimated into the brain of the patient. We studied them in the anterior cingulate cortex here, and we showed that there was, at the end of the 3 nights and after the recovery sleep, an overall decrease in glutamate. And this decrease in glutamate was proportional to the decrease in the Hamilton ratings and was proportional to the increase in perceived mood. So they are correlated, highly significantly correlated, changes in glutamate in frontal cortexes and changes in depressive symptomatology. And we know that this enhancing glutamate during wake is one of the core mechanisms which underpin the net synaptic potentiation which happens during wake and depression which happens during sleep. By targeting basically these glutamatergic mechanisms and other things, intracellular mechanisms such as glycogen synthase kinase 3 beta and many others that we have not time to see here, it has been shown that during wake animals improve, they increase their synaptic weights. There is a long-term potentiation in cortical neuron synapses, and these synapses go down during sleep, and this has to do with glutamatergic mechanism, and it is at the basis of the so-called synaptic homeostasis hypothesis, which postulates that synapses increase during the wake as a function of learning and synaptic potentiation linked with activities and whatever, and go down with the synaptic downscaling during sleep and especially during slow wave sleep in a homeostatic process which we surmise it is disrupted in patients affected by bipolar depression. And it can be studied. It can be studied because there are combined transcranial magnetic stimulation and high-density EEG techniques to evoke potentials into the cortex, which correlate in animals with the actual synaptic weights. So in humans, by using these techniques, we can derive measures of the synaptic plasticity and of the synaptic potentiation which goes on during the sleep deprivation treatment. These are healthy subjects, sleep deprived. You can see that their synaptic weights had gone down during the previous night of sleep, but then they increased during the day, and they continue to increase after sleep deprivation, and when they go to sleep, they go down, and then the cycle starts again, okay? And Paola Canali, together with other of the group of Massimini, worked with us, and we studied this thing in our patients. So we tried to see if this mechanism worked differently in patients who were good responders or poor responders to treatment, and we found that it was so. So we recruited a group of patients with good response or poor response to the antidepressant treatment with repeated sleep deprivation, studied this mechanism, and showed that in the whole group, in a comparable way to the patients affected by, to the healthy subjects, the patients affected by bipolar disorder had a net synaptic potentiation during wake, which was further increased by the sleep deprivation night and then went down. But look at two things. First thing is that this pattern is closely similar to the one observed in healthy subjects, but there is a difference. The sleep at baseline does not change anything. These patients do not have the natural oscillation in synaptic plasticity, which is observed in healthy condition. And the second point is that the final point is much higher than the baseline. So that we have a net effect of synaptic potentiation. And this effect is very different in patients who respond and in patients who do not respond to treatment. The blue patients respond to treatment very well. The red patients do not respond to treatment. The pattern is the same, but you see that it is downscaled. And the final point, which is reached by non-responders who, please remember, they had some kind of amelioration but did not reach the response criteria, the final point is lower than the baseline point of responders. And the other very, very interesting thing is that these baseline things do not change. You see at the baseline sleep change nothing, but after this treatment it changes a lot, so we probably restore the normal homeostasis of synaptic plasticity which goes on during wake and during sleep in normal condition and which is completely flattened during bipolar depression. And that's a core correlate of the mechanism of action of this technique. And by the way, Paola Canali is here, and tomorrow we'll present exciting new data about oscillatory natural high frequencies in bipolar disorder, major depressive, and schizophrenia in a poster. So chase her, and if you are interested in these things, she will explain better than me what she did. And the second thing that I wish to tell you is that by targeting this system, we touch the core areas which are involved in the experience of emotions. In the top-down control, in the frontal limbic circuitries, which takes a top-down control on the amygdala and the subcortical nuclei and bottom-up influence of these nuclei to the cortex. And years ago, we had shown that effective sleep deprivation changes the neural responses to emotional stimuli in a moral valence decision task. We had shown that, it's a very complicated slide, but just look at here, that good responders enhance the reactivity of the dorsolateral prefrontal cortex, I mean the same areas which we have shown now, enhance their also cortical plasticity. Neural reactivity is enhanced in the front of negative stimuli, and it is decreased in front of positive stimuli, thus restoring the top-down control in the cognitive control of affect and emotions and in the generation of affect, and this does not happen in no-responders. And now we have shown with Benedetta Vai, who's here, so chase her if you want to have details about this, we mapped all the cortical circuits from the entry of the stimuli at the level of visual cortex, and we showed here that good responders to treatment have an enhancement in the effective connectivity from dorsolateral prefrontal cortex to anterior cingulate cortex, and this enhanced connectivity is significantly shown in good responders and does not happen in non-responders. And as a correlate of this, the bottom-up reactivity to negative stimuli is decreased in responders and not in non-responders. So we restore a balance in which the cortical limbic circuitry control the reactivity of the brain to emotional negative stimuli by enhancing the cortical control, and this is a correlate of an enhanced synaptic plasticity in the cortex. And this is important because in an independent study in my group, we had shown that these bottom-up influences from amygdala to cortex in front of negative stimuli do correlate with suicidal ideation. The higher the connectivity and the channeling of stimuli and information from amygdala to cortex in presence of negative stimuli, the higher the suicidal ideation of patients. Both these two studies have been published a couple of months ago, so you may find it on the internet. And final point, final new correlate, which I think must be explored, is which has to do with the possible disruption of white matter integrity in bipolar depression, which we proposed as a possible structural marker of illness. We show that we deeply think that these problems in connectivity, which we observe at the functional level, may have structural underpinnings in a disruption of the white matter integrity of the brain, which can be studied with diffusion tensor imaging by showing that we have an enhanced mean diffusivity of water into the brain, but more importantly, we have an enhanced diffusivity of water perpendicular to the main axis of the white matter fiber tracts, which should be coated by myelin sheets, but we observe that water crosses them, so these myelin sheets should not be so much good as they are supposed to be in keeping the axons coated, okay? And these measures also have to do with the structure of the axons and the microtubular structure of the axons. So probably a combination of the two things, changes in the microstructural, tubular microstructure of the axons and directionality of the axons, and changes in myelin sheets integrity contribute to this result, which is significant. We have shown in these white matter tracts, especially significant in the white matter tracts which connect the frontal limbic circuitries, the dorsolateral prefrontal cortex with orbitofrontal cortex, with cingulate cortex, with the amygdala, and not in these bottom circuits. So these circuits are also physically disrupted, okay? There are changes in their microstructure. And we have shown lifetime with Irene Bollettini and all my co-workers, and she is also here too, that effective treatment, such as lithium, in the lifetime counteracts this detrimental disruption of white matter associated with the illness and improves the axial diffusivity of water, so probably improving both neuroplasticity in the long time by improving the structure of axons and also having a trophic effect on glial cells, oligodendrocytes, and those restoring the proper coating of fibers. And we will now again present, I think, very exciting new data. Sarah Poletti will present a poster in a couple of hours, so look for her at the poster session, showing that effective chronotherapeutics with this same treatment that I showed you increases axial diffusivity. This is very similar to the effect obtained by lithium and may explain why the two treatments are so much synergic. So we are targeting, by manipulating the sleep-wake cycle, the core mechanisms which regulate the homeostasis, the water homeostasis of the brain, and probably all the homeostasis of the brain of the synaptic plasticity processes. And we don't know how we do it. I'm just telling you what we are going to explore, what we are actually exploring now, which has to do with major changes that can be observed in the structure of the extracellular matrix in the brain across the sleep-wake cycle. Water is actively pumped through aquaporins into the brain, and animal models, that's a paper published on Science some years ago, show that there is a 60% increase in extracellular space during night and during sleep, and this increase in water content in the extracellular space is the mechanism by which sleep drives metabolite clearance from the brain. And we suppose that having flattened this homeostatic cycle of synaptic plasticity and of this mechanism in our patients who sleep so bad at baseline, these mechanisms are probably disrupted. And so metabolites are not cleared from the brain, and all kind of stuff, I mean neuroinflammation markers, whatever, stays there and contributes to that self-reinforcing state of depression, which leads the patients to desperation, hopelessness, suicide, and whatever. So what we are studying now are these core mechanisms regulating cellular and brain homeostatic functions, and we hope in a near future to be able to present you data on this. In the meantime, of course, there are a lot of people who made all this possible. Some of them are listed here. So I thank you for your attention. We will be at the poster session if you have questions, technical questions about what we did. We have a lot of posters on these brain imaging mechanisms, and we will be happy to answer any question you may have. In the meantime, thanks very much for your attention.